Hello, I'm Dr. La Rosa, and today we are going to review the gross examination of heart, kidney, and genitourinary specimens. We're going to start with the examination of the heart, in which we need to remember that there are two different possibilities that we can have a heart specimen. First is the conventional autopsy specimen. The whole heart is being obtained, whereas in the case that is most common for all of us, in the transplantation procedures, the explant is a heart that it has to be sectioned at the level of the atrium to be able to leave the pacemaker that is present in the right atrium. First, we're going to review some very general aspects to be considered. Remember, we are physicians, no image diagnosticians, and we also always have to have the examination of any specimen in the context of the clinical diagnosis and also the imaging information in case that we have it at hand. So all these together is going to help us to assess the organ that we are going to examine. So in case that there is some problem with the specimen and it has some difficulties in the orientation or the presence of some rare abnormalities, discuss this case with the pathology assistant or with the attendant. I'm happy to come over to the laboratory to be able to help you in the processing. And then it's very important to take photographs, especially of the fresh specimen, because when you have fixed overnight, the color and many other things are going to be a little bit changed. So it's very important. You can take later on pictures after fixation, but it's very important to have it fresh images, both for the purposes of diagnosis as well as for teaching. The first approach after that external examination is to weigh the specimen and measure it, and also provide any kind of information in the external examination. If the heart is too big, is dilated, or if there is some kind of alteration of the morphology or in the configuration of the great arteries. Sometimes there is some switching in the morphology of these, some congenital abnormalities. And then the pericardium is there is not only adhesion, but also if there is hemorrhage. Many times we can find an aneurysm or breaking of the muscle wall that needs to be important for this description as well as for the picture that you're going to take. And then also in a secondary way, how much pericardial fat is present. Once we finish with the gross examination, with the overall view of the specimen, then we have this outline that you can find in the laboratory in the gross room, in which we have basically the sequence of procedures that we need to follow. We are going to start first with the dissection and the description of the coronary arteries, noting their course, size, dominance, etc. And then once we have removed the coronary arteries, in some cases, some of the residents are very good at this kind of dissection, and they can remove the whole branch of the arteries with even some of the collaterals, and then we fix it overnight. And if we find that it's some calcifications, then we put them to calcify. And this is important also to make cuts once they are fixed in every 3 millimeters intervals, because many times they can be very focal thrombi that if you take sections that are too long, you're going to miss these lesions in the middle of the section. So it could be not only thrombi, but also plaques that can be producing obstruction. Then describe the degree of luminal narrowing in percentage, kind of eyeballing, and then any kind of characteristic lesions that you can also find. Take pictures of those sections as well, and then at the minimum should meet the areas that are more affected by narrowing, and then include this in the different cassettes to be able to differentiate the left, the right, and the circumflex, etc. So look for stents as well, in case that you, before you start cutting, you want to be able to see if there is some kind of a metallic mesh inside these arteries, and describe the location, how many they are, and their appearance. And then in some cases, and this is a different kind of a specimen where it's not an autopsy, it's not an explant of the native heart, but it could be also an explant of an allograft that was previously done. Many patients have, after several months or years, what is called coronary allograft vasculopathy. And it's extremely important to examine the coronary arteries in those specimens as well, because they may have also the explanation of recurrence after another allograft is placed. So we go for next step, and we are going to kind of braid loughing the heart from apex to mid ventricle, about 3 or 4 transverse slices, about 5 millimeters in thickness each one. Take pictures, lay the slice in sequence, and take pictures of all of them, and then close-ups in case that you find areas of necrosis or hemorrhage or any kind of a thinning of the wall. Very important also is in cases that we have kind of congenital cardiomyopathies. Some of them, they are focused on the right ventricle most importantly, and that is the presence of fat. If you find a very significant amount of fat within the myocardial wall in the right ventricle, in most cases, in some cases you can also find this kind of fat deposition in the left ventricles as well. And the presence of this fat is going to interfere the conductivity of the signal that comes from the right atrium. And then it's going to produce blockages and also arrhythmia. And then there is a very interesting pathology that's called arrhythmogenic right ventricular dysplasia, in which the presence of fat is the one that in the wall of the right ventricle is going to interfere with the normal physiology of this muscle. So also take pictures in a kind of these situations in close-ups, and also describe all the appendices, the atrium, and then describe where the section has been made to remove the explant, because the rest of the atrium is going to remain in the patient, that is going to continue producing the pacemaker function for the transplanted organ. So describe any kind of chambers, abnormalities, they are dilated or they are thin, there is hypertrophy, aneurysm, etc. And also any kind of alterations, as I mentioned before, in the not only in the pericardium, but also in the endocardium. They could be thrombi, fibrosis, hemorrhage, etc. And please pay attention to this last note, that hearts with congenital malformations must be reviewed by the pathology assistant or the attending pathologist prior to dissection, because it's very important. Most of these cases may be present in pediatric pathology, but still many patients can live or survive these kind of malformations and then die of that malformation or complications of that malformation, and we need to be aware of that as well. So continue with the description of the different aspects of the parts of the heart, the valves. The cardiac valves are very important. They usually, sometimes you need to be familiar with the normal morphology. If they have normally only 2 valves or 3 valves, and then see if they have any kind of fusion, or there are any kind of abnormalities that can be important calcifications. Also, the presence of malformations. Measure all the circumference, not the diameter, because the diameter is from one border to the other border of the circle. You have to open the valve and measure what is the distance for the circumference. And in addition to what I already described in regards to the coronary circulation, we need to describe the presence of any hardware, as we mentioned at the beginning, and try to be very specific, describing that particular device, and write down the trademark of the hardware, and also in case that is present, there has a serial number that is very important in case in case that there is some kind of a posterior legal or medical legal implication. And always remember that, of course, there's no two patients that are the same, not two organs that are the same, and every heart is different. And then in addition to the conventional sections, you really need to focus in the areas that can be more abnormal or that require microscopic examination. In general, you can take samples of lesions in different aspects of the heart, the anteroseptal, anterior, anterolateral, etc. So you can, as well as the right ventricle and the septum, to be able to identify these particular lesions. Also, take sections of the mid-ventricle to include the papillary muscles. Sure that the sections are transmural, including endocardium and epicardium. And if the tissue is too thick, then you can divide them into different cassettes or two different specimens in the same cassette. So the endocardium, as you may know, is very important because many pathologies can be present in the endocardium or subendocardial, like vegetations or sometimes ischemic changes or some thrombi that can be present in that area. So remember to write up always the list of the most important pathological processes that you are finding. So this is going to help you posteriorly to finish the case. And when you describe the disease, remember that not all the alterations you're going to find in the heart are going to be the primary pathology. Many times, for example, fibrosis is a consequences of an infarct, of ischemia, and the consequences of a coronary artery disease. So you have to have that kind of a order in the way that you interpret the pathophysiology of these lesions. So give the order of priority. So if the patient had myocardial damage, the most important thing, in addition to mention the damage, what is the origins of that damage? In cases there is a coronary artery disease, there is an obstruction, etc., etc. So there is a kind of an algorithm in reverse in the way that you have to describe these lesions. This is an illustration that can help you to identify the location of these arteries. For example, the right coronary artery, it has a particular morphology and location, as well as the aorta, pulmonary artery, etc. And this circumflex the left coronary. So you need to get familiar with this kind of morphology and the description, both in the anterior as well as in the posterior aspect of the heart, how the circumflex goes around, and this the name comes from that location, from that morphology, etc. So all these aspects, you need to be very familiar with the anatomy of the heart before you start trying to describe abnormalities in this organ. And this is just to give you an example of what we can do with the pictures. For example, in this particular heart, you can see that this area of the right atrium is almost gone because it has been sectioned to leave it in the patient. So that right atrium can also command the transplanted heart for the pacemaker physiology. And then you can also do pictures of that and explore the area as well and describe it properly as I mentioned before. And also in the cases that the organ comes with some hardware, you can see, for example, here there is what is called LVAD, or left ventricular assist device, that is being helping the patient to survive because the left heart is insufficient. It doesn't have enough power to produce a good blood pressure, and then they have to put this pump that is going to help to project the blood through the proper aorta and compensate the lack of function of the heart in this particular patient. And again, you need to check on the brand, if there is some branding an inscription in the device, if there is some serial number that also can help for identification. And in this other area of the heart, you can also see that there is a tube that is also helping for the distribution of the blood that is connected to this specific device that you can see in the eye apex of the myocardium. And continue with examples of the different abnormalities that you can find. Here you have a left ventricle that it has a very severe uh, uh, rupture, loss of continuity, that it was done by the rupture of an aneurysm. The patient had a previous myocardial infarction that weakened the wall of the left ventricle, and eventually this produced an aneurysm, and then the aneurysm rupture, and then basically the patient went in the cardiac arrest, and that was basically the reason why this patient had to be transplanted right away. And as you can see in this very nice picture that is being sectioned, the heart, the same case that I showed you before with the aneurysm, the specimen, the half of the heart basically has been sectioned from the more apical aspect to the kind of a more medial aspect of the heart, showing the presence of this aneurysm with the opening that here with this has hemorrhagic areas, especially in these sections at the very left of the specimen. So these sections were, or these lesions were produced in the patient itself before he was grafted. And you can also see that there are some sequela of the previous myocardial ischemia with the necrosis and thinning of the left ventricle. And this is very nice illustration of what you can do with the coronary arteries if you can do a kind of a careful dissection. You can see that the right coronary artery is here very nicely depicted here with some irregularities here, and also the left coronary artery as well is very well dissected, where we are going to be able to identify lesions there. And as I mentioned before, you can section them every 3 millimeters intervals to avoid the missing specific lesions that can be inside the lumen of these arteries. And in some cases, you can do even a dissection of the coronary arteries without fixation. And this is a case of an autopsy case when I was doing some coroner office work many 25 years ago. And this patient had been, was about 55 years old, and was complaining of indigestion. So everything, his symptoms were related to the GI tract, and he was feeling this pressure. He was taking antacids and things like that. And then suddenly he was with his family and died. And then basically what happens is that this clot, these clots usually are developed in very few minutes, because you have the atherosclerosis around that still allows the passage of blood, but eventually there is a formation of a thrombus, and that's why what causes the sudden death in these patients. So there was no time for any transplant or anything like that in this particular case. And going to another part of the heart that is very important, here you have a tricuspid valve that it has a very severe vegetations and also fibrosis that is also altering the normal flow of the blood and producing cardiac insufficiency, as you will know, depending on which valve is being affected. Now, in regards to the specimens that we can receive in our pathology gross room, we need to mention that in many cases there is a reception of explant samples. They don't send us, they don't send the whole heart, but they send basically a piece of the left ventricle and a piece of the right ventricle. So they are sent to the pathology after they went into the research cardiology lab, where they took the whole heart. They sometimes, unfortunately, only they send you an additional report with the most important measurements of the heart, the weight, etc. Just recently, we just signed out a heart that originally was 500 grams, but the heart that we received was only 350 grams. So they have removed a very significant amount of tissue and was not able to basically study that part of the tissue. But in many other cases, you still don't have the whole heart. You just only have these pieces that we say in Peru is just a piece for the cats because it's basically not meaningful and it has basically no context. But we can study the coronary arteries or other structures of the heart. So in those cases, you have to include a very good description and in your worksheet, and then measure and weight the specimen and submit several representative sections. Sometimes we are lucky and we find lesions in those pieces, but these are random pieces that they don't have valves, they don't have coronary arteries, etc., and we have to deal with them. This is an example of what I do. I have already a template, and I say final diagnosis, heart explant with no gross description sometimes. Yeah, and I was submitted, and then only the random section from the explanted organ, and then whatever you find, then you include it in the diagnosis. And then I always put a comment: this diagnosis is limited because the whole heart specimen was not received for a gross pathology examination. Only two small random samples, left and right ventricles, submitted without information of the gross anatomic features of the entire specimen. Unfortunately, we have tried to talk to our colleagues in the cardiology lab, and sometimes they remember to send us an additional description of the heart, and many times they don't. Now I'm going to show you a video that I have edited. This is a video that I took from the YouTube, and it was produced by the Department of Pathology and Laboratory Medicine of the Whale Carnan Medicine Hospital, and I edited a couple of years ago. And it was entitled Gross Examination of the Heart Explants, specific explants. So here we are seeing the separation of the aorta of the pulmonary artery, and then this has an important part of the procedure to be able to make the dissection, starting from the coronary arteries first, and then be able to isolate them and make the dissection that we were talking about before. And then we are going to see the left coronary artery and the circumflex, that they are already being partially dissected, and the course that I have now, they are showing the circumflex, and they're going to proceed to remove it. And this is something that I think that if you pay a little bit of attention, we were able to get a very nice dissection of the artery out of the myocardial tissue. Now we're trying to approach the right coronary artery, and this course into the right ventricle. And again, trying to get the area where it's coming out of the aorta, and then some of the more peripheral aspects. In this particular case, they haven't fixed the vessel, but they are proceeding to make these sections that I mentioned before with 3 millimeter intervals, and then representative sections, especially the areas that are more concerning for obstruction, are submitted in the corresponding cassettes. And it depends of how much involvement of the atherosclerosis and thrombi you're going to find that you can submit more. Now this is a very important part, that is the breadth lobe of the myocardium, starting with the apex and about 4 to 5 millimeters thickness, but this is done only up to the half of the heart before the location of the valves, and then we can align the different sections in a consecutive order to be able to take the corresponding pictures. And now we are going to proceed with the opening of the right atrium, and then from there we're going to go into the right ventricle and produce an exposure of the cavity of the right ventricle. You can use either bisturi or a blade or just good scissors to get the section done. As you can see that not all the heart has been sectioned, but basically about 1 or 2 centimeters from the valves you will stop making this section. So here they are using a forceps for the introduction of the knife and be able to get a very nice cut, and with the exposure of the valves and the corresponding veins and arteries. Here we are describing, showing the measuring of the circumference. As I mentioned, we don't measure the diameter but the circumference of the valve. And now the right ventricle is being also opened to expose the pulmonic valve. And again, the forceps helps to guide the scissors and make a kind of a clean cut. So the tricuspid pulmonary valve and the pulmonic artery are exposed, and then so we can measure the circumference again. Now the left atrium is going to be opened through the pulmonic veins coming from the lungs that are bringing oxygenated blood, and they are going to the left atrium first and then into the left ventricle. So the left ventricle is also approached through the left atrium, and then the mitral valve is exposed in a similar way that we got exposed of the tricuspid valve in the right ventricle, measuring the circumference and also checking if there is any lesion, vegetations, fibrosis, fusion of the valves, and now exposing the completely the left ventricle by making a section through the aortic valve into the aorta to be able to see the corresponding aortic valve, and also describe what we've done before, measure the circumference and also any kind of lesion that can be present. The measurement of the thickness of the wall is about 1 centimeter below the tricuspid valve or the mitral valve, correspondingly either for the left or the right ventricle thickness. In this case, from one of the sections of the heart, we're taking representative sections as we described before in the different anterior, posterior, and this is important not to produce very thick sections, because otherwise the histologist technicians are going to blame you in case that there is no good processing of those samples. We don't want to have it thicker than the thickness of a coin. And be very specific in regards to the areas that are being taken. So this is a summary of the representative sections that we also show in a previous slide. Okay, so with this, we concur the presentation. This was the credits for the video that I just showed you. Okay, now we are going to continue with the gross examination of the kidney and the genitourinary specimens. We are going to start first with general steps, and was again with general identification of the specimen, with correlation with the clinical history, and then the gross description that it has to follow a particular protocol based on this College of American Pathology, the guidelines. The submission of tissues is very important, because the same protocol of the CAP indicates the kind of sections that it has to be taken from this as a product of the gross examination. We're going to start with the examination of the kidney. That this is a graphic cartoon taken from the same CAP protocol. The presence of, in this particular case, tumors in the parenchyma, the renal parenchyma itself, and also tumors that can be present in the pelvis. And then different possibilities that we can find in regards to the extension or the invasion of these tumors into different areas, either the perinephric fat or the sinuses fat and the area of the pelvis. Okay, so first we are going to have this summary of the gross examination, continuing with the same kind of order in the protocol, starting with the weight of the specimen, measurement, especially of the renal vein and ureter are present. And this is very important. When many of the cases of kidney radical nephrectomies come with a good piece of ureter, and the ureter is considered as a different organ. So for the purposes even for charging CPT codes, the ureter should be treated as a completely different entity. And then if we are talking about a nephrectomy and then a good portion of ureter, more than 5 centimeters, I will use kind of a round on length to consider that it's a partial or a complete ureterectomy. So when we describe these specimens, we always need to remember that the ureter has to have a particular handling as an individual organ. And also in the moment of diagnosis, we need to put the kidney and ureter radical nephroureterectomy, and then put as a subtitle the kidney and the diagnosis of the kidney, and then ureter and the diagnosis of the ureter, even if the ureter doesn't have any pathology. But many cases, the ureter also has tumor. And I've seen many cases that we request the resident to do, to go back to the bucket and then get hands of the ureter and opening ureter, because in the description of the gross examination, the ureter not described that it's being open, and then representative sections are taken. The fact that the ureter is taken doesn't mean that it has pathology, but in some cases it may have it if we don't look for it. So this general examination is going to be very important in regards to the presence of surgical margins, that you have to see the distance of the tumor to the renal vein margin in sections that can produce a very good histological slice. And then C is the tumor grossly is just protruding areas outside of the kidney, like through the capsule, or it's just pushing the capsule out without infiltrating the capsule. And the same thing in the case of the renal vein margin, is it is just a thrombus, or is the tumor is also invading the wall of the vein at the level of the surgical margin. So in regards to partial nephrectomies, we have to be very careful in the examination and identify what is the capsular component and what is the real surgical margin with the kidney parenchyma. So we need to properly ink the specimen to identify with different kinds of color ink the capsule and the surgical margins with the renal parenchyma to be able to identify them in the histological examination. Now, regarding the radical nephrectomies, it's a little bit more complicated because we need to take consideration that there are several areas in the kidney, do a good breath loaf of separating and opening the kidney, taking all the measurements that are necessary, examine the location of the kidney tumor, and also be able to identify which one, what the location of the tumor is, if it is in the upper pole, in the middle pole, or the lower pole, because many times there is no description of that. And it seems that sometimes there is confusion in regards to which one is superior and which one is inferior in regards to the orientation of the specimen. So you have to measure the specimen, take pictures as well as the broad, not only of the outside of the kidney, but also sort of the inside, to locate exactly where the position of the tumor is and the correlation with the cortex, with the parenchyma, and also with the areas of the pelvis and the ureter, even in case of the tumor is extending at that level, and also check of the relationship of the tumor with the main vessels, the renal vein, and if it is part of the inferior vena cava, document that and correlate with the surgical report. It's extremely important you read the surgical procedure, the notes in EPIC, to be able to correlate the findings that you have in your hands with the specimen. So all these aspects that are outlined here, I'm not going to go in detail, but they're also outlined in the CAP protocol. Here we have a nice illustration of the kidney that is also presented in the CAP report. You can see that the different stages, for example, when the tumor is invading the pelvis or the pelvic fat, or also invading the perirenal fat, or invasion of the adrenal gland. The two types of invasion. One could be just by extension from the parenchyma into the gland, or it could be a discontinuous tumor that is not connected to the main tumor, and it can be considered as a metastasis into the adrenal gland. Now, this is a very nice picture of a partial nephrectomy in which the sections have been aligned in correlation from the more the closer to the renal parenchyma, as you can see here, all the way to the more peripheral aspects of the tumor, where you can see very well that there is the size of the tumor, or also the presence of the parenchyma. In this case, it's kind of a variegated with areas that are lighter and the areas that are hemorrhagic, sometimes with kind of cystic formations, most typical for a clear cell carcinoma in this particular specimen. Here we have an external view of the kidney with the tumor that is kind of probably involving the perirenal or the capsule, and also most likely after the sectioning, you can see the parenchyma of the tumor with the correlation with other renal structures. In this particular case, we see that the tumor is very located in the more medial area of the hilum. The differential diagnosis could be urothelial carcinoma in the pelvis versus tumor that is closest to the hilum in the renal parenchyma. So this is something that it has to be very well examined, and representative section needs to be produced correspondingly. And also see if the tumor is going into the ureter, as you can see here. Apparently, the tumor is not peripheral, so there is no concern about the capsular involvement in this particular section. Here is another representative section of a typical clear cell carcinoma with this variegated morphology, that even though the tumor is pushing on the fat, but you can see that there is a very nice limitation with a capsule, a kind of a fibrotic capsule that, even though it appears to be localized in the area of the pelvis, but it's still not involving the pelvis. In the next one, we have another tumor that here we have the cortex. The tumor is extending from the cortex all the way into the pelvis. But as you can see again, that even though the fat is here kind of next to the tumor, you can envision that there is a little bit of a limitation with a fibrotic capsule in which the tumor is still contained within the renal parenchyma with no really invading into the pelvic fat. This is basically the gross summary that you need to have. It comes from the CAP protocol, and where you have to include all the basic elements of the tumor with the extension even, and also the different kinds of the gross examination. This is another graphic in cases of urothelial carcinoma in the renal pelvis. When we talk about kidney tumors, we always need to remember that the renal tumors is not only the renal parenchyma, but the pelvis also corresponds to the kidney. And these tumors have different stages in cases that they are just located to the surface of the urothelium, or if they start invading the subepithelial, the lamina propria, connective tissue, or if they go all the way to the muscularis propria, giving us the different pathology stages that you'll be very familiar with that. In this case, this tumor is not only invading the muscle, but it's also invading part of the renal parenchyma, and that is considered a PT3 stage. Here is a typical tumor in the pelvis, as you can see, that is kind of molding the size of the pelvis. Apparently, it's not really involving more further from the pelvis, and then you can also, in this case with this forceps, we have lifted this area of the tumor when we see the implantation, and this particular case didn't have invasion into the subepithelial tissue or the renal parenchyma. Here is another tumor that it has appearances of more aggressive, with probably involving not only the surface, but also going deeper into the underlying subepithelial or muscular tissue as well. And then again, always remember that every ureter that you find, it has to be dissected and cut longitudinally. In this particular case, there is a small polyp formations that they were found in the microscopic examination to be areas of urothelial carcinoma papillary type with no evidence of invasion. Again, in the uretero-pelvical tumors, we also have to have the same kind of protocol to describe the gross examination with different aspects of the location and the measurements. And then we pass to examine the urinary bladder as a different specimen, the genitourinary tract. Then the frozen sections of in first case, sometimes we need to get frozen sections to evaluate the margins, especially the urethral margin. Many times it's not obvious the involvement, but if there is a tumor that is too close to the urethral margin, it may produce evidence of either invasive ureteral carcinoma or carcinoma in situ. About 3% of the positive ureteral margins in one study suggests it should not be done. In one study suggests it should not be done routinely. So this is a low incidence, but in case that the surgeon is suspicious that this could be a positive margin, it needs to be examined with frozen sections. This cross sections of the distal ureter is important, not chafed margins. And then the freezing artifact is something that is always going to be present. And whoever is doing frozen sections is going to find that the atypia is sometimes very bothersome, because it sometimes the nuclei are a little bit enlarged, and we are not able to completely rule out the presence of cancer. And then our internal ruler, remember always, the lymphocytes or the red blood cells, they're about an average between 7 to 9 microns in diameter, and anything that is 2 or 3 times larger than that, it should be considered suspicious or atypical. Then, especially when we have these weird tumors that have a plasmacytoid pattern of the tumor that can mimic inflammatory cells, we need to be aware of that, especially in the frozen sections. Anyway, so we go to the examination of the urinary bladder itself, in which we are going to have a very important 2 different specimens. One is the transurethral resection of the bladder tumor, and the other is just a partial or radical cystectomy. It is very important to stress the fact that for TERP specimens, we need to weigh the specimen. There is a tendency, and I don't know where it's coming from, that the pathologists, even outside pathologists, they measure this kind of lump of very irregular fragments of tumor that, as I always say, it doesn't matter in which position you put them. It could look like a little cluster of tissue or like a flat tortilla, and in those cases the measurements are going to be completely different. However, if you weigh the specimen, it's always going to be exactly the same amount of tissue that you're going to be measuring, because if the patient is 2 grams, it's going to be 2 grams regardless of the form or the way that you want to put them on the you want to put it on the dissecting table. So the transurethral resection of tumors, usually we want to submit entirely, but however, we need to have some consideration, because sometimes they are very large tumors. We have sometimes tumors that are 100 grams, and that will imply several trays of slides to examine. So we'll see later on what are the limitations for that. And in the case of cystectomies, it's very important to ink all the external surface to be able to assess for the margins, and then open the specimen anteriorly with a Y-shaped incision. And then after you have opened the specimen and taken the pictures, then you can fix it overnight to be able to do these sections. Don't cut the specimen more during the stage that is fresh, because it can produce very irregular sections. But it's extremely important that you open the specimen and put it into a cork base, or a kind of with pins around, to be able to expose all the internal aspects of the specimen, because if you just put the urinary bladder without sectioning, without opening, it's going to fix very nice the external aspect of the bladder, but the internal aspect is going to be rotten, and you are not going to be able to have a very good histological evaluation. Now, again, all these are part of the protocol of the CIP. Document all the measurements of the organs, the location of lesions, and any kind of extension that could be suspicious outside of the organ, especially in cases of invasion of other neighboring organs. In the case of margins, the patients in women, we usually have to take it, these urethral margins in face. And then in the case of men, we have to be careful in the urethral margins, also in face, or as an apical cone with perpendicular sections, because they can also be involved with prostate cancer, or the urethral, the bladder cancer is extending into the prostate, either one of those two possibilities. So it is very important to be able to evaluate properly the urethral margins when we have a radical cystectomy or a cystoprostatectomy. So it's important to examine the areas with suspicious lesions if they have invasion that can go deeper into the lamina propria, the muscle, or even the adipose tissue, the vesical adipose tissue. And also, we need to take random samples because CIS is not obvious in the gross examination, and we need to be careful to be able to sample properly. These are just another representation from the same CIP protocol, just to identify the different aspects in a radical cystoprostatectomy in this particular case, and also the relationship. Most of the cases, the males are going to have a radical procedure, including prostate and bladder. In women, it's just the bladder that is being taken, and in some cases, it's also accompanied by the uterus and adnexa or sexual organs. So going back to the transurethral resection of bladder tumors specimens, remember that to submit one section or one cassette per centimeter of tumor diameter, so up to 10 cassettes. If the tumor is non-invasive by the initial sample, we need to add additional cassettes, etc. And in cystectomy specimens, we need to have representative sections that go deeper into the bladder wall to be able to evaluate invasion of underlying tissues. And these are just kind of a outline of the different kind of sections that have to be submitted that you can also access in your protocols at the gross laboratory. Starting for the tumor, representative sections of the tumor, and also the different margins that are extremely important. These are the summary that you need to include in your report. With we have these templates already in our Exchange folder, where you can copy them and you just basically remove the ones that are not correlated with the specimen that you are studying about, and put all the information that you are obtaining from the gross examination and also from the microscopic description. Now, in the case of lymph node identification, you need to dissect the lymph nodes both in the cystectomy and other specimens, because there are some local lymph nodes, and those the identification of at least 12 or more lymph nodes is recommended according to provide a good follow-up in these patients. It's been already established that the larger the number of lymph nodes that are obtained during the radical cystectomy procedure, they are significant in regards to the rate of recurrence or metastasis later on in the life of these patients. So try to be careful in obtaining the largest amount of lymph nodes. Many surgeons are careful about that. And if you provide them only 2 or 3 lymph nodes, they're going to complain, and sometimes we have to go back to the bucket and try to get more lymph nodes for evaluation. Then the most important aspects that we are going to evaluate is basically the stage of the tumor based on the depth of invasion, going from the T0, that were the very superficial tumors, or PT1, that when they are invading only the lamina propria, or PT2 when they are invading the muscle, and depending on the depths of invasion, we can subdivide the PT2A and PT2B, and then the PT3 is when the fat outside of the bladder is being involved. So this is a very nice help. These are just some examples from the gross examination that you have taken pictures, and I have chosen the nice ones. This is a very weird, a very thick wall for this particular cystectomy, and in which you can see that inside there is a presence of a large tumor with some papillary appearance, and most likely with the areas of invasion deep into the muscle and likely into the fat tissue. Here is a better exposure of the specimen with this large tumor, and then the possibility of invasion in deeper levels, in which you have to sample meticulously. Again, more details of this papillary tumor with these areas of extension. And then this is another tumor that kind of a little bit of a weird dissection. This is very regular, but you can see here that some areas suspicious. Sometimes when these patients have had a previous TURP and removal of the tumor, we're going to find the ulcerative lesions or the scar lesions that look very suspicious as well. So I try not to call them tumor or malignancy. We can just call them nodular lesions, more descriptive in regards to what they look like grossly, because many times, as I said, the tumor is already gone, and then the only thing that we have is the sequela of the surgical procedure. So it's better not to get involved in describing the nature of these lesions in the gross examination. You can describe them as nodular formations or a scar or ulcerative sections, lesions, but try not to give them the nature of the lesion, especially in regards to the presence of malignant tumor, when it's just only the gross examination that you are assessing. These are just other pictures just to document some with nice pictures and the presence of these tumors. This is another bladder. Here is the urethral margin. Here there is some lesions, and most likely ulcerative lesions, not necessarily tumor. And this also likely could be a tumor, but sometimes the sequela of the previous surgical procedure can look like this, especially if it's been recent. So, of course, we need to do a thorough sampling of these areas just to see if there is some kind of residual tumor. Here is another case of a very typical tumor. Here, very papillary, and then all this area that it appears to be solid with this kind of a more homogeneous appearance and going deeper into even the fat. So this is very likely the presence of tumor that with a very deep involvement of the bladder wall. And then, of course, we need to be very careful in taking deeper sections, even at the level of the surgical margins. Now, passing to the penile pathology, here this is also a very nice section cartoon provided by the CIP protocol, in which you can see that the different anatomical layers of the penile organ, starting with the most superficial ones in the skin and going into the deeper ones, with the dartus, corpora cavernosa, etc., that are going to be used as a reference for the depth of invasion of these tumors that are going to be correlated with the staging and the prognosis of these patients. Here, this is a cartoon also of the tumor that is present in a partial penectomy, and then after submitting the proximal resection margin, the patient is cut in half longitudinally, and then parallel cellular sections will follow. So you need to take a very good sampling of the real margin, and then the correlation, the section is important here because if the tumor is starting in the surface of the glands, in this case, and is going into the urethra, is a very high stage that is going to be different in regards to prognosis to the presence of only tumors that are more superficial. So we need to be careful when we do this kind of dissections and also be able to identify the different components of the cross-section of the penile specimen. And then here we have one real life whole radical penectomy, but the tumor here is in the most inferior aspect of the penile organ. This is circumcised, and you can see that part of the skin has been left probably in the patient, because here we just see the underlying connective tissue. Then this tumor, you can see that it has this fistula, most likely produced by some necrosis. And then when we dissect or we do the cross section, longitudinal section, as we've seen before, of the penile organ, you can establish a better correlation between the superficial tumor and then the tumor that is deeper and even invading the urethral tissue. It seems that the tumor has grown in such a way in this particular case that it has occluded the normal urethra and has produced this fistula that in the base of the penile organ. So here we have a nice margin that we need to sample, and also sample at different levels to be able to identify the presence of tumor in relationship with the different layers of the penile organ. This is just a close-up to illustrate this tumor that most likely started in the glans penis and then has extended into the urethra and adjacent tissue in this organ. This is another specimen also that you can see the large tumor that is likely started here. There is tumor in the glans penis, but its extension is through the erectile tissue and also in the dartus and also the urethra. So very advanced tumor with a high grade. This is a partial penectomy just in the glans penis, also with the presence of some tumor that has in the background of the erectile tissue that is more pink and kind of spongy. You can see that the tumor is represented by these areas of more uniform appearance. Then going to testicles, remember always that we need to make these nice sections of the specimen to be able to expose the epididymis, the retitestis, and also the presence of the tumor in relationship with the testicular parenchyma, and see if there is exposure of the tumor into the tunica albuginea or the tunica vaginalis. Tunica vaginalis is going to be very transparent. Sometimes the tumor can protrude or can push, but not invade the tunica vaginalis. So it's important to take good samples of these tumors, especially when they are very peripheral. And also the presence of tumor in relationship with the epididymis or erected testis that can also be involved. This is a external appearance of a radical orchiectomy with the testicle and then the epididymis and then the spermatid cord, that it has to be also very well studied and sectioned. Here is the section of the testicular parenchyma with a very interesting tumor that it has this kind of very homogeneous and light yellowish, white yellowish appearance, that it looks like a fish meat. And then this is typical description for the seminomas, for example, that it has a very homogeneous, probably with a central necrosis, and is very well circumscribed, as you can see here. And then this is another example of a seminoma, very well circumscribed, present in this nice dissection of this testicle. And then we, again, take representative sections of the tumor itself and areas that most likely could be also suspicious by extension. And then you can see here there is any one particular area that could be suspicious for involvement of the albuginia, and but the lining of the vaginalis probably is still intact, and any kind of other suspicious areas that can involve the spermatic cord as well. Now, when we have this kind of tumors, this is a very large tumor that is involving the testicle, but it has a very irregular appearance, variegated, and this most typical is the representation of a mixed germ cell tumor, in which we can find components of different origins, embryonal, yolk sac, even teratomas. So we need to take samples of all the areas, different areas with different aspects, because since this is not homogeneous, sometimes this area could be just embryonal, pure embryonal. Some areas could be just a hematoma, teratoma, and also other areas like yolk sac or seminoma. So these kind of tumors have to be very well sampled to give a final, in cases of a mixed germ cell tumor, a final assessment of the percentage of the different components of these tumors. This kind of tumor is very interesting because this has a completely different appearance as compared with a seminoma or a germ cell tumor. And this is a choriocarcinoma. This choriocarcinoma can also be accompanied by other parts of a mixed germ cell tumor, or be just pure choriocarcinoma. So we need to explore and take samples representative at different levels. This typical tumor with all these cysts here, with that large kind of a fibrotic appearance, is typical of the teratomas. So teratomas are going to have this cystic appearance in the gross examination, but still, you don't know if there is some mixed germ cell tumor components in other areas that we need to be careful to sample religiously in all the areas of this tumor. And finally, we have the gross examination of the prostate. In this case, the prostatectomy specimens usually not taken to the residence, and we have a special laboratory for special specimens like prostate, because our laboratory is a center for research, national and international research in prostate cancer. So we have a special procedure that I'm going to illustrate later on with this video. So if you just do a little scanning of this QR code, you are going to go to the this YouTube website that is called Denver Pathology, in which you are going to find some other interesting presentations that I have done in the past, and also other colleagues have done. So you will see in full detail how this procedure for degrossing of the prostatectomy specimens is performed. It's an 8.5 minutes video. And also, I would like to invite you to see some other videos in this, for example, for the grossing. They are not mine. These are just from the different other authors in regards to the grossing of the genitourinary specimen, especially in the urinary bladder. And also here one for cystoprostatectomy, and also this reference that is very interesting in regards to gross examination and the sampling of surgical specimen from the urinary tract. So if you point to the specific QR codes, you are going to be able to access these very interesting videos. Yeah, with this, I think that we already took more of our time. Thank you very much for your attention. And please, since this is a video, I am not able to be present in person. So if you have any questions, please don't hesitate to send me an email, and I'll be happy to reply right away. Thank you so much.